I'm Bryce Peterson. I'm a third year, as you very well guessed. I'm a local boy as well. I grew up down in Bountiful. I went to the University of Utah for my undergraduate training, and then out to the Ohio State University College of Medicine for my undergraduate medical training, and then I'm here, obviously, for my family medicine training. I've taken a job down in Monticello, practicing full-spectrum rural family medicine, as God intended it. My talk today is entitled Diabetes Insipidus and Exercise, and I specifically want to talk about some clinical considerations that we should think about in the athletic population. This is a sculpture entitled Mannequin Piss. It is Dutch from the early 17th century, and replicas are surprisingly all over the state. How do I advance the slide? What clicker? This thing? Okay. Green, thank you. What'd I do? Green button. Yeah, I'm pushing the green one. There we go. The other green one. As far as disclosures, unless IHC invested my 401k in Sanofi Aventis, who manufactures DDAVP, I don't have any. Brief overview. I'm going to present one case and then talk about diabetes insipidus for a little while. After we talk about the treatment, I'm going to present a second case and go over some of the complications that can be expected, and then also talk specifically about considerations we should think about in the athletes. So the first case, 27-year-old male presented to a sports medicine clinic, primary care sports medicine clinic, reporting a 12-year history of trauma-associated hypopituitarism, including central diabetes insipidus. He came in after having completed a sprint triathlon and noted that he had this dull, diffuse headache that lasted for quite a while afterwards. He says, I really don't think this was related to training. I've been training pretty regularly for over 6 months for this. I'm worried that this was related to my fluid balance. Is it safe for me to keep doing these, doc? And at the end of the visit, he also says, oh, by the way, I also took a little extra dose of my DDAVP just to be sure I didn't run out in the middle of the course. So we examined him, fairly unremarkable exam. So being scientists, we set up an experiment. We did 2 mock triathlons, the first with his normal dosing of desmopressin that he took intranasally the night prior to the race. He then came into the exercise lab and did a sprint triathlon in the pool, on a stationary bike, and then on a treadmill. Reported no symptoms whatsoever. We monitored serum sodiums and compared them to our second mock triathlon, where he did the same protocol but added his extra dose of medicine that he had taken before his original triathlon. And he did note that he had a mild headache for several hours after this triathlon. You can see there at the bottom the differences in the sodium really have no difference. I didn't do any statistical analysis, unfortunately, but I guarantee it's not statistically significant. So what did we tell him? Well, don't take any extra medicine. Just don't do it. And our original hypothesis was that maybe he was retaining a little bit of extra free water because of his extra dose of desmopressin. Obviously, that wasn't supported by our very small trial, but could this have been due to a pop science version of the Heisenberg uncertainty principle, where the patient was aware of what we were measuring and monitoring and thus changed his own behavior? Possibly. He was better educated, maybe. Either way, we told him, go about your business, keep doing this, which he did, and has had no other problems. So let's talk a little bit more about diabetes insipidus. Really, it all revolves around arginine vasopressin, which is the hormone formerly known as antidiuretic hormone, or ADH, or vasopressin or pitressin, depending upon when you went to medical school. Just a brief reminder of the physiology of it. It's synthesized in the supraoptic nuclei and paraventricular nuclei of the hypothalamus, transported down those axonal stalks to the posterior pituitary, where it's then secreted into the systemic circulation, acting on the V2 receptor in the distal collecting tubules of the kidney. It increases the reabsorption of free water, thus concentrating the urine and diluting out the blood. Once the blood hits a certain dilution point, it acts on the serum osmoreceptors in the hypothalamus and shuts down this loop. So the pathophysiology, there's a couple different options for where this can break down. The first is you cannot have any arginine vasopressin. A complete lack of it is central DI. And this, the analogy to the more common diabetes would, of course, be type 1 diabetes insipidus. For nephrogenic DI, this is due to an insensitivity to the receptor, obviously analogous to type 2. And then there's, interestingly, a transient DI of pregnancy, which really just underlines the point that pregnancy is a terrible, terrible thing. But extreme levels of cysteine aminopeptidases cleave the arginine vasopressin that these poor women are making them pee all the time. And fortunately, it goes away after they deliver. The epidemiology, it's about 1 in 25,000. Males are equal to females. This means that there's probably 80 to 120 people in the state of Utah with this disease. Leave it to me to pick a zebra. Most common causes are tumor. Idiopathic causes have got to be prominent in any disease this rare. And then trauma, whether it's surgical or the more common type, and stroke, granulomatous diseases, including tuberculosis, sarcoid, histiocytosis X, and other infections have been attributed occasionally, and then birth defects and genetic causes are prominent, but unlikely to present in the adult population. So diagnosis is all based around measuring serum osmolality, having an elevated serum osmolality in the setting of an inappropriately dilute urine. If this isn't present when the patient first presents, then you can consider doing a water deprivation test. The simple way to describe this is you don't let them drink, you monitor them very closely because you're not letting them have any fluids, and then you measure their urine and serum osmolality. Once their urine osmolality bottoms out, you give them some desmopressin and watch what happens. If after an hour their urine osmolality comes up quite a bit, then they have central diabetes insipidus. If it doesn't come up much or it doesn't come up enough, then they probably have nephrogenic DI. If the picture is still gray, you could consider testing an AVP level, an arginine vasopressin level, but this really isn't usually necessary. And then another important diagnosis to consider would be psychogenic or primary polydipsia, where the patient is simply taking too much water, has washed out their electrolyte gradient in their kidney, and they're not going to respond either, because their body is actively trying to remove free water appropriately. So treatment, desmopressin, it's the synthetic AVP, formerly known as DD-AVP. That's 8-deoxy, 8-deamino arginine vasopressin. It's very selective for the V2 receptor. The V1 receptor I didn't mention earlier is in the vasculature. We don't see any blood pressure effects from this. You can give it any way you want. I've never heard of PR dosing, but it would probably work. And the literature does say that increasing doses should lead to increasing duration, not an increase in effect. We'll talk about that a little bit more at the end of the talk. Other treatment considerations that we should also remember are that these patients should be having medication holidays to ensure that they allow their body time to control or equalize their other electrolytes. And then they should also monitor their weights, much like a CHF patient, to see if they're retaining any free water. I want to discuss this second case, which brings up a few other complications. This case was also in Ohio, but out in Toledo. A 40-year-old male marathoner came into the clinic to his primary care doctor complaining that his wife was complaining that he was getting up too much in the night to pee, 3 or 4 times of nocturia. He did note that he was more thirsty, and it had come on fairly slowly, but 3 or 4 months. His initial exam was very unremarkable. Initial labs are right there, all normal. He did have a urine osmolality that was low, and he went on his way, and over the next month, his symptoms got better before he followed up with anyone else. Unfortunately for him, they came back abruptly 2 months later. And at this time, a further physical exam was done. He did have normal visual fields and normal visual acuity at that time, and then the rest of the exam was normal as well. Labs obtained at that time, however, were not. You can see the sodium was elevated. I should point out this was Ohio, so his hemoglobin of 18 is somewhat unusual. And then his serum osmolality was elevated, his urine osmolality was inappropriately decreased, and then he had an impressive 7.5 liters of urine output over 24 hours. So imaging was the next step. He had an MRI that was noted to have this infundibular thickening to 5 millimeters. This is not his scan, but from the literature, a similar case. And you can see the widening of that midline structure there as it descends towards the sella turcica. Other imaging included renal ultrasound and a chest x-ray, both of which were normal. So suggesting central diabetes insipidus. We gave him, or he was given desmopressin, and his 7.5 liters of urine magically went away, and he went back to running. About 6 months later, he was ready for another race. He wanted to, this was like number 12 or 13 marathon for him, and he had a fluid plan of 4 ounces every 2 miles. And he ran the first half of the race at about a 6-minute per mile pace. He then, as he had planned, decreased his pace, or increased his pace, dropping down to around 5.5-minute miles. He came in just a short time later to the aid station at mile 16, dizzy, confused. One of the volunteers gave him a big jug of Gatorade, which he quickly consumed, and his mental status improved. He tried to run out the gate and finish the race, but appropriately, the volunteer stopped him from doing so. He came back to see his physician and said, "I just don't get it, doc. I took an extra sniff of my medicine so I didn't run out midway through. What happened?" Well, I think we can gather from this largest case series of diabetes insipidus in athletes that has ever been presented that patients should not take any extra medicine. And then also their pre-race training really should evaluate their own personalized sweat losses and fluid needs. The literature will cite sweat rates anywhere from 0.5 liter to 2 liters for athletes. So estimations are worthless. He was taking 4 ounces every 2 miles. That means he was only 32 ounces in by mile 16, which is probably an hour and a half into his race. He got better with a hypotonic solution. This gentleman was not overhydrated. He was probably dehydrated. But because of his diabetes insipidus, he was worried. Thirst mechanisms must rule in these patients. Now, obviously, if a thirst mechanism were damaged, be it by the surgery that gave the patient diabetes insipidus, this isn't going to be effective. But in a patient with diabetes insipidus and an intact thirst mechanism, they must rule. These have to be how these patients are managed. Particularly, and the asterisk here is to say the thinking brain, well prepared with knowledge of their own personalized sweat rates and fluid needs, is what must direct these patients' rehydration. This is a protocol for optimal hydration evaluation that the USA Track and Field put out. The long story short is weigh yourself, go run for an hour, measure how much you drank, weigh yourself again. Any decrease in your weight is, you need to add that to how much fluid you drank during the run. It's not rocket science. Other things that we should instruct these patients on is that we need to remember that treated athletes with diabetes insipidus basically have SIADH. They should be monitoring their weights carefully. They should have a good understanding of their own sweat rate. And if their thirst mechanism is impaired, they need very careful monitoring to make sure that they're okay. They should think about a medical alert bracelet in case there is an issue. And then I think it's worth counseling them that they should avoid any extra doses, as both of these patients independently did this just for fear of having to take too many potty breaks. Brief word on hyponatremia. This is the hot topic with marathons and other endurance events. Exercise-associated hyponatremia is almost certainly acute, so we don't have to worry about all the catastrophic events of correcting their sodium too quickly. If they're not that symptomatic, then don't do anything for them. But if they come into your tent and have a seizure or are profoundly confused, you could consider giving them a 3% hypertonic saline, small bolus, while they're getting up to the ICU. Key points, I think these patients need better counseling on monitoring their weights and medication holidays. We should tell them to stop taking extra medicine, and they need to have a good understanding of their sweat rate and fluid need before they engage in any of these type of activities. Thank you very much.